Uh, Ravi, good morning. Ravi is a consultant hepatobiliary surgeon in Edinburgh Royal Infirmary since 2017, and he's a clinical director there now. I just give you a brief background of Ravi. It's all started with Ravi's father-in-law, Dr. Thirumalai Swami. I think he was doing surgical training in around Manchester in 70s. I don't know whether anybody remember. He went back to Europe, and Ravi got married to his daughter, and that's how I came to know Ravi. He came to UK in 1993 and stayed with me as a clinical attaché in urology, Pontefract, West Yorkshire for a month. Then from there, he climbed on. He did his junior surgical training in Blackburn. Then he went to Scotland. I don't know why. He did postgraduate training in Aberdeen rotation. And Aberdeen liked him so much, and they offered him consultant post in 2002. But Ravi liked Edinburgh, so after 5 years, he moved on to Edinburgh, and he's still there. He's blessed with 2 children, a son who is training to be a gastroenterologist in Oxford, and his daughter who is going to be a trainee in radiology in Edinburgh. Ravi, over to you.
Thank you, Raju, for your invitation and your kind introduction. Elil, thank you for being a co-host. And I thank you, all of you, for spending your beautiful sunny morning here, sitting in front of your iPhone or the laptop to listen to my talk. Let me just share my screen. Can you see my screen now?
Yes.
Yeah.
Okay. Yeah. When Raju asked me to talk about liver disease, I am very passionate about liver in general, because liver is an organ which sits right in the middle of your body if you measure from top to bottom. And it's got its own aura. It attracts both physicians and surgeons to look at it. It approximately weighs about 2% of your body weight. Maybe in a 75-year-old man, it may weigh about 1.5 kilograms. And it is the metabolic factory of our body. Unlike heart, lungs, and kidneys, they shout when they're not well, whereas liver suffers silently. As a HPB surgeon, I deal with 2 different organs, main organs. One is the liver, the other one is pancreas. So it's like one is very forgiving, which is the liver, and pancreas, it punishes you for whatever you do. It's like a wife and girlfriend type of relationship. I leave it to you guess which one is which.
That's a take-home message for us then.
Yeah. We all here today, maybe there is something something you're looking for. Some of you may be in general practice, and some of you are specialist gastroenterologist or hepatologist or training to be a gastroenterologist. And you may be a hepatobiliary surgeon or a transplant surgeon or a hospital specialist in different clinical specialty. You may have a friend or a family member with a liver problem, or you may have risk factor yourself to develop liver problems in future. So there are various reasons why people come onto this talk, I think. I structured my talk mainly to give a magnitude of the liver problem. And when you come across an abnormal liver blood test, what you do, and my experience as a liver surgeon, particularly in the hepatobiliary field, I'm not going to concentrate on management of individual liver diseases today. That'll be another day. If you look at this chart, this is measurement of standardized mortality rate throughout UK from 1970 to 210. you can see, apart from one line at the top, every other diseases involving other organs, the mortality rate over a period of 40 years are coming down. Whereas mortality associated with liver diseases have increased about 400% in this 40-year period. If you look at people less than 50 years old, the mortality has gone up by 500%. I mean, the liver suffers silently because of its own fault. It has got quite a lot of reserve in it. In England and Wales, in 2012, there were over 50,000 hospital admissions, and nearly 20% of those admissions secondary to liver diseases died. In other words, if 5 people are admitted to hospital with liver-related disease, only 4 of them will get out, 1 will die. The 3 most common causes for this are alcohol-related liver disease, non-alcoholic fatty liver disease, viral hepatitis, and recently autoimmune-related hepatologic diseases joined the queue as a 4th cause. I just put up 2 of the studies to show the magnitude of the problem. One is from England. In University Hospital Birmingham Foundation, from 40, I can't see the number here because the from 82 GP practices, from 82 GP practices, they received over 130,000 liver blood test requests over a year, and only 30% of them had at least one abnormal value. That's quite a big number. Just 1 year in Birmingham area, nearly 40,000 people had abnormal liver blood test. Similar type of thing was replicated in north of the border, near my place, Nine Wells Hospital in Dundee. Over 15-year period, they look at the blood test done in primary care, and 25% of the adult population in that area had abnormal blood test. And 1/3 of the patients who had abnormal value, subsequently, so 1/3 of them had abnormal value, similar to what happened in England, but only just about 4% of them who had abnormal value in their blood test developed liver disease in about 5-year period. So if you look at 100 people having abnormal liver test, only 1.3% had liver disease. I mean, this is a very large population. Up to 25% of them can have abnormal blood test, but only about 2% of them will have or will develop significant liver disease. If one develops liver disease or liver failure, then the mortality is high. Those with significant liver disease will benefit from early input from specialist care if it's done in time, and the outcome will be better. If it's delayed, the outcome is going to be poor for them. How do we, as doctors looking after patients in primary care, in secondary care, not specifically in gastroenterology or hepatology, identify this small group of people with significant liver disease and refer them to correct place in correct time without burdening the resources in the secondary care or tertiary care? This is going to be very tight balancing act. To address this question, a lot of people done very good work and published a guideline in 2017. This is published in Gut. Some of you, particularly in the general practice, may be aware of this, or you may not be familiar with this guideline. And some of the recommendations I'm going to make subsequently are based on this paper. When do you do liver blood test? But before we do talk about liver blood test, I think conventionally, when I went to medical school, and like most of you, we're all taught as a liver function test. But liver function test, when people ask them specifically, what do you mean by liver function test? They mainly mention about liver enzymes. The liver enzymes are mainly inflammatory markers or injury markers of the liver cell, and they don't really measure liver function. So it is a misnomer, and it's better to use the word liver blood test rather than liver function test in this scenario. In asymptomatic patients with obvious clinical evidence of chronic liver disease like ascites, evidence of portal hypertension, hepatosplenomegaly, then it's reasonable to do blood test, liver blood test. Or patients who are suspected to have viral hepatitis, either because the country they come from or because of their parental exposure, it's reasonable to do the liver blood test for them. And there are people who are at risk of developing liver disease. For example, people who are known to have other forms of autoimmune disease, it could be thyroid autoimmune disease or kidney autoimmune disease, but they are high risk of developing autoimmune hepatitis. So that's a high risk group if you have other autoimmune diseases like rheumatoid arthritis and other things. And similarly, people who got inflammatory bowel disease like ulcerative colitis or Crohn's disease, they have higher risk of developing primary sclerosing cholangitis. So that's another group of people. And more commonly, people with metabolic syndrome, the four big things about hypertension, diabetes, obesity, and mid-segment obesity particularly. And these are the group of people with a higher risk of developing chronic liver disease in future. And if you are going to treat patients with a hepatotoxic drug, typical example being rheumatoid arthritis treated by methotrexate, for example, and certain drugs which can cause fatty liver, steatohepatitis, and vascular injury, particularly simvastatin group of drugs. And if someone has got family history of liver diseases, metabolism of copper or metabolism of iron, hemochromatosis or Wilson disease, and sometimes people may have non-specific symptoms, fatigue, weight loss, body ache, which may be a manifestation of underlying liver disorders. So these are the group of people where you want to think about doing liver blood test. When we say liver blood test, we doing this blood test mainly to identify a small group of people, as we talked about earlier on, and refer them early to secondary care or tertiary care so that their outcome may be better. So what do we mean by standard liver blood test panel? So standard liver blood test panel includes 3 different group of tests, mainly hepatobiliary enzymes. Usually in the past they used to do ALT, which is alanine transferase, and AST, but nowadays they do ALT. But you could ask for AST specifically in people who you think is high risk, particularly people with metabolic syndrome, people with hepatitis C, with chronic IV drug abuse, and people in that group. Because the AST and ALT ratio, if it's more than 1, that gives a good marker or indicator as a prognostic indicator for future development of liver fibrosis. So alkaline phosphatase and gamma GT are the other enzymes we do. Alkaline phosphatase is produced by biliary epithelium and is indicator of bile duct obstruction. It could be intrahepatic or extrahepatic biliary obstruction. As you know, alkaline phosphatase is produced not only in the biliary epithelium, it's also produced in placenta, it also produced in the bone. So children in growing age, they will have high alkaline phosphatase, and pregnant women will have high alkaline phosphatase. So measuring gamma GT will differentiate whether it's coming from liver source or alternative source. Say if gamma GT also elevated, so it's probably related to liver. And if you want to really measure liver synthetic function, the 3 common measures are bilirubin, albumin, and prothrombin time. Because they are the active, really measure the functional capacity of the liver. And thrombocytopenia is a marker of hypersplenism secondary to portal hypertension in this scenario. So If somebody hasn't had full blood count in the past 1 year, it's recommended to repeat them and measure platelet count as a marker of liver fibrosis. So this is a standard liver blood test panel. Once you have done the standard blood test, based on the results, you divide them into 3 main groups. In the patients with isolated raised bilirubin, which usually indicates Gilbert's as long as other enzymes are normal. And if you want to confirm that, you can repeat the blood test by prolonged fasting that will raise it further. And one of the differential diagnoses will be hemolytic anemia when you have isolated bilirubin. You can look at the full blood count panel and specifically ask for reticulocyte count, and that will show that will be increased in patients with hemolytic anemia. The green box in the middle with the cholestatic group is the most surgeons will come across this group of people is due to cholestasis, either due to sinusoidal obstruction, whether intrahepatic obstruction or main bile duct or branch duct obstruction, secondary to inflammatory diseases like primary biliary cholangitis or primary sclerosing cholangitis, and it could be drug-induced. Common drug which we come across is comoxiclav in clinical practice. As I mentioned before, you need to be aware of raised in alkaline phosphatase in childhood due to natural growth spurt producing high alkaline phosphatase. And also it's recognized now people with vitamin D deficiency will have isolated raised alkaline phosphatase. So you'll be looking for a wrong area if you're investigating more on the liver and not correcting the vitamin D deficiency. And the third group of people are people with hepatic or hepatocyte injury, secondary to non-alcoholic fatty liver disease or alcohol-related fatty liver disease, alcohol-related liver disease, and it could be drug-induced or autoimmune hepatitis also. Like any other information in medicine, we can't go with just one value. If you come across an abnormal liver test, then you need to look back, particularly did the patient have any previous blood test and has there been any altered liver function test in the past, and past medical history, particularly concentrating on liver specific history and their current medical condition, including drug history. Magnitude of altered enzymes itself does not really matter. For example, if somebody has got hepatitis A, the transaminase may be over 1,000. That is not so bad because hepatitis A usually heals and liver resumes full recovery soon. Compared to hepatitis C, for example, they may have mild derangement of LFTs. Transaminases may not be very high, but in the long term, that can cause chronic liver disease, fibrosis, cirrhosis, and a problem with the liver failure. So the magnitude of derangement of liver test does not really matter. It's a chronicity. And it's been in the past, somebody comes with abnormal liver function test, usual response would be just repeat it. You know, this study has looked into, it's a ballot study from Midlands, it came through. They looked into abnormal liver function tests and followed them up. If you repeat blood test in all of them, 84% of them in a 1 month time, they had abnormal LFTs again. In fact, when they repeated 2 years later, 75% of the adults had abnormal liver tests. So just repeating the blood test without delving into identifying the cause for abnormal liver function test, you're only delaying the uneventual outcome. So the other study, which is ALFI study from Dundee, so in that study they said, if we ask patients to come back for a repeat liver function test and only 50% of them came back or 50% of the results were looked into, so you may miss big proportion of people just by repeating blood tests. So if you have one abnormal test, then that should trigger investigation of the etiology of the liver disease. So if you just to ask for a repeat appointment, so it's not going to be cheap either. One of the reason people do repeat test is hoping it will go away. But repeating is another appointment. It has to another blood sample to be taken. Sample has to be transported to the laboratory, and there's a cost in the laboratory to process it. And patients may not turn up, the patient complains, and inconvenience to the patients. So by repeating it, we're not gaining anything. We may lose a significant proportion of patients getting appropriate treatment early. So before we go into further management of it, what are the urgent indications for patients to be sent to hospital within a week or 2 weeks' time? Yeah? So we need to know that, so that the remaining patients, we can manage them in the primary care as well as we can. And so if somebody had unexplained jaundice, particularly if there is a suspicion of hepatobiliary malignancy underneath it, like a painless jaundice, that's one of the indication of admitting to hospital or sending an urgent referral in a 2-week pathway. Also, if they've had evidence of advanced liver disease, cirrhosis with portal hypertension, which is not known before, it's a first presentation, they probably need to have quicker workup, not routine outpatient workup. So they need to be sent in sooner. I mentioned about when you notice abnormal liver function test, or sorry, I'm saying function test again, it's just a habit, abnormal liver blood test. So we need to go much more in depth to look at all this history. I just leave it for a minute for you to look through. I don't need to read it again. Once you've gone through, the next step up, the standard liver blood test is the first step. The next step would be standard liver etiology screen. And this is for adults. I'm completely omitting children because they are a completely special group of people and that needs special expertise to be, seen by pediatric hepatologist. But I'm just concentrating on the adults. So the hepatitis serology, and these are some of the tests done mainly to look at patients or pick up patients who will benefit from some intervention early on. And so the standard liver etiology screen also includes abdominal ultrasound scan, because ultrasound scan picks up echo bright liver. When the fat content in the liver goes up, we call fatty liver, over 30% ultrasound can pick up. It can also pick up obstructing pathology like a tumor in the pancreas causing obstruction of the bile duct. So it can, even though you may not be able to see the pancreas, you may be able to see the obstructed bile duct with the dilatation outside and within the liver. Once you've taken the history, once you've done basic and the liver blood test, and also you've done the second step blood test, and then you will recognize the clinical pattern, whether they have, I don't know whether you can see the pointer. So from the history, if you have suspected alcohol attached risk, then they have a separate algorithm, which I'll show you later on. If they come in with urgent category, either with the synthetic failure, suspected malignancy, which we talked about earlier, they get urgent referral. If they have an isolated bilirubin with otherwise normal blood tests, they're usually secondary to Gilbert's, or some of them, very small proportion of them, have hemolytic anemia, but most of the hemolytic anemias would have been picked up as a child, so very unusual for them to pick up as an adult. Then we have a isolated cholestatic liver enzymes or hepatic liver enzymes. They all get liver etiology screen, ultrasound, and then based on the flow chart, we go into diagnosis of NAFLD, where non-alcoholic fatty liver disease, which is very common in people with metabolic syndrome. The risk factors are type 2 diabetes, obesity with BMI more than 25, dyslipidemia, and hypertension. Then you follow them up either in your GP practice, but if they have, then based on the scoring system, you can kind of predict how high the risk is for them to develop liver fibrosis. If they have very high risk of developing liver fibrosis, then they are referred to hepatology clinic or gastroenterology clinic locally. If they have low risk, then we can see them back in the clinic once in 6 months, just make sure they modify their lifestyle and you control the diabetes and hypertension appropriately. In the presence of echobright liver on the ultrasound, in the absence of excessive alcohol consumption, is called fatty liver. And when you identified fatty liver, then the non-invasive assessment, there are two different types of score. There are lots of scoring system. These are the two different types of scoring system, which is widely used currently. And this is, for example, the FIB4 level can be measured only based on age, AST, ALT, and a platelet count. It's very easy, and it's a computer online calculator which you can make it. And if the fibrosis score is high, then they get referred to gastroenterology clinic or hepatology clinic for further workup. And the basic management for them is change in lifestyle, calorie restriction in the diet, increased physical activity with the long-term goal of appropriate weight management. So that's all reduces the risk for non-alcoholic fatty liver disease. If they are low or medium risk, they could be very well managed in the primary care. So this is what I mentioned earlier on about the FIB4 scoring. If it's a low risk patients, they are managed in primary care. If it's high risk, they go to hepatology clinic. If it's intermediate risk, they go for second test of what is called a fibroscan. This is a type of ultrasound scan where they measure, by sending ultrasound wave into the liver, they measure the elasticity of the liver. In other words, to measure how hard the liver is. The harder the liver, the worse the fibrosis is. So it's one way of measuring if they are intermediate category. And if the fibroscan also shows that they have fibrosis, then higher risk, they go into the hepatology clinic. If the fibroscan is reassuring that it's not very stiff, then they can come back to the low risk pathway. This is patients who have got significant alcohol history. One of the things about people, when they take history, alcohol history, we take most of the time how much alcohol you drink and what do you drink. And not very many people go into much more details of not only alcohol consumption, but the alcohol consumption associated behavior. And that's very, very important to predict how good, how bad they are going to be for advice in future. If they are drinking in excess and they are harmful drinkers and they are high risk category and they go for fibroscan, and they also need to be referred to alcohol services to give counseling to reduce the alcohol level. There is a questionnaire called audit questionnaire. Audit questionnaire is alcohol use disorder associated. And that questionnaire is about 10 different questions. Each has got 5 options in them. Whereas Audit C questionnaire is a kind of abridged version having only 3 questions. And that also predicts the risk of them for the how good or bad they are with alcohol consumption, alcohol behavior. So, for example, if their alcohol intake is low, meaning the audit scoring system, if they do full audit questionnaire, if it's less than 7, they are lower risk of developing alcohol-related liver disease in future. unless they have other associated problems like a metabolic syndrome as well. That's completely different. So once you've done all the blood test, first line and second line, and the ultrasound, then if the abdominal liver function test triggered the second line, and then you've done ultrasound scan of the abdomen, and there's all been negative, and because ultrasound can only pick up if the fat content of the liver is more than 30%. So what will you do? You go and revisit the history, whether you missed any drug history, including over-the-counter preparation, herbal medications, recreational medications. So these are some of them which probably won't, usually don't get so much of history, much more in detail. And identify, do they have risk factors for NAFLD? Then if they do have risk factors, then they should be going to NAFLD pathway. If there are no risk factors, then you can repeat the liver function test again. If they are persistently elevated, then we need to refer them to secondary care referral, because there are a small group of people with autoimmune hepatitis may have negative autoantibody. So this is another exception where you can repeat the blood test before you refer. So there are two group of people where you repeat them. So by good history and examination with the standard liver blood test and standard liver etiology panel combined with ultrasound, most of the time you'll be able to identify a treatable cause. And risk assessment fibrosis in appropriate patients and early intervention to reduce progression helps in this small group of people. That finishes my first part of the talk. And the second part of the talk is, as a HPB surgeon, I've been doing liver surgery since 2002, as I was appointed as a consultant. So I have seen in my time developments in the liver surgery. It's a long time since first successful liver resection was done. A lot of people would have used Langenberg retractor in a lot of operations. It's very common. Carl Langenberg is the first person credited for 3 different operations. He's the first person who did nephrectomy when he was 31 years old, in 1870, I think. And then he did the first cholecystectomy successfully, and he did the first successful liver resection. He's a German guy, such an aspiring surgeon. And 1950s, there've been a bit of a lull, because without proper anesthetic, without proper blood transfusion facility, liver surgery has been very bloody, and there've been very high mortality associated with it. So there's been a bit of a lull since the first liver resection. And in 1950s, slowly reports of liver resections came from America. It was 1952, it was Lothar Jacob in France. He did formal right hepatectomy with proper vascular control. But in 56, Claude Cunard, he is the name in liver surgery who revolutionized it. He published the book Liver, Anatomical Studies and Surgical Studies, in that he described portal flow into, portal vein goes up and divides into right and left, and the right divides into anterior, posterior, left divides into medial and lateral. So he divided the portal flow into, and then divided the liver into 4 different sectors, and subdivided that into 8 segments. So I just put in this picture for clarity. So that's the inflow of the liver. So you got common bile duct in black, and hepatic artery in red, and in the front, in the back, portal vein in gray. So that's the inflow of the liver. And then you see on the top, that big tube, that's the inferior vena cava, which goes right in the back of the liver. And that has got 3 hepatic veins, right, middle, and a left hepatic vein. So these 3 veins divide the liver into various bits. And the middle part, or middle vein, which runs from inferior vena cava right through it and to the gallbladder fossa in here, and that divides the liver into right lobe and into left lobe. So the right lobe is supplied by right branch of hepatic artery and portal vein and bile duct. They all go with each other, and they divide into anterior sector, and which is segment 5 and 8, and post sector 6 and 7. And left goes, and then it divides into medial sector, which is segment 4, and lateral sector 2 and 3. Segment 1 is, you can't see them because it's right in the back in this area, behind the liver in front of the IVC. When you see the liver from the surface, it looks like one big globe. There is no surface marking apart from the gallbladder and 1 or 2 fissures in the inferior aspect and falciform ligament and right and left triangular ligament. You don't see any of that, what you see in this picture. Description of liver anatomy and liver imaging. These two things have revolutionized understanding of the liver surgery. In the past, the liver surgery associated mortality used to be over 20 or 25%, but that has come down to less than 5%. In fact, most of the high volume centers now report less than 1 or 2% mortality associated with the liver resection. Depending on how much liver do you remove, how you remove it, there are different names associated with it. So if you, for example, if you just remove a little chip out of the liver like that, there or there, it's called atypical resection. You're not identifying formal segmental anatomy and taking it out. But for example, segment 2 and 3, if you cut in this area and remove the segment 2, 3 intact, so that's called a segmentectomy or bisegmentectomy. If you take just one segment, is a segmentectomy. And if you remove 3 segments, either left side or right side, 3 segments or more, that constitute a major liver resection. And if you take 4 plus, or more than 4, say for example, if you take the right lobe, which has got 4 segments, and take part of the segment 4, it's called extended right hepatectomy. Whereas on this side, take the whole of left lobe with a part of the right lobe, it's called extended left hepatectomy. And then you can do various permutation combinations of which segments you take, as long as you leave behind 2 contiguous segments together, which is good quality with adequate blood supply, biliary drainage, and venous drainage, and that liver will grow and compensate the liver function subsequently. So you may be able to take out, as long as the remaining liver is normal, you can take up to 75% of the liver, and remaining 25% will grow with the time. Takes roughly about 4 to 6 weeks for it to grow. When I was a surgical trainee, I was asking my professor in Stanley Medical College, I asked him, so what shall I do? What shall I do? There's a small lump in the liver. Hey, கட்டி இருந்தா வெட்டி எறி. அதை ஏன் நீ நினைச்சு அந்த டெஸ்ட் இந்த டெஸ்ட் பண்ணிட்டு இருக்க? That's how he used to tell me. So that's gone a long way now. So the liver imaging has revolutionized over past few years. CT scan has been in the way for a long time, but the way they do CT scan with high resolution scans, with the contrast in different phases, so that makes big difference in interpretation of the pathology and the anatomy of the liver. Now ultrasound, now we have different types of contrast like a sonar view, where you can kind of characterize the lesions much better by looking at the vascular characteristics. And similar, MRI, which is a different type of energy, and they use different type of liver specific or bile duct specific contrast, and that gives much better resolution in certain types of tumor. And CT PET scan, which is a functional scan, so it picks up hot activity. Usually tumor is very hot and benign conditions are not, a normal liver is not. So you can pick up abnormal hot area in a part of the liver by doing a CT PET scan. So if you identify a mass lesion in the liver, it could be a benign condition, which is the commonest cause will be a liver cyst. A lot of people are born with it and they die with it. It doesn't cause any problem. And can get focal nodular hyperplasia, which is also a benign condition. And hemangioma is like a birthmark. And liver cell adenoma or bile duct cell adenoma. The liver cell adenoma is common in young women who are on oral contraceptive pills containing estrogen, and they have, particularly if they are big, they have higher risk of developing hepatocellular carcinoma in it, and they have higher risk of bleeding, rupture, bleeding, particularly during surge of hormones during pregnancy. And primary malignancy, hepatocellular carcinoma, intrahepatic cholangiocarcinoma, and hilar cholangiocarcinoma, they may present like a liver mass lesion. And secondary malignancy from colorectal primary is the most common secondary malignancy we see in the liver. And of course, you do see renal metastasis and unusual tumors like neuroendocrine liver tumors and gastrointestinal stromal tumors spread to liver as well. When we see patients with pathology, all patients coming through the unit, they are discussed in multidisciplinary meeting. Just because they have lump doesn't mean that need to be treated or taken out. There's a good group of people are actively managed by active observation without any intervention at all. Once you decide that you want to treat the condition, there are various options of treatment available. One is a liver resection, obviously, which we talked about very briefly. Then the newer treatments are ablative treatment, radiofrequency or microwave or electroporation or different types of energy. What it does is you put in a probe percutaneously under ultrasound guidance into the middle of the tumor and activate the tip of the probe. It generates intense heat, like a globe of heat, and it burns the tumor as well as the liver tissue roughly about 3 to 4 centimeters. So if you have a tumor of 2 centimeters, you place it right in the center and it burns about 3 centimeter globe with 1 centimeter normal tissue, normal liver, so that you guarantee you have burned the tumor. So that's increasingly being used, particularly in cirrhotic patients where surgical resection is a higher risk. And also they have a hard liver with a soft tumor in the middle, so easy to insert and ablate it. So liver transplantation has taken off very big way throughout the world, including developing countries. And that's a big option which has been going on since 1990s in the UK and from late 1990s in other places. Other type of treatment like a local regional chemotherapy and local regional radiotherapy are available, and systemic chemotherapy is very valuable, particularly in people with secondary tumors. They're not so much in primary tumors, but in secondary tumors like a colorectal liver metastasis. Once you've decided this patient is for a particular treatment, particularly if they're for resection, then they need to be fit for the operation, and they should have a good exercise tolerance. The kind of a rule of thumb is if they can walk a mile, if they can climb up flight of stairs, with a flight of stairs with a bag of shopping in their hand, and that's good enough to have liver resection. And if they have alcohol excess or chronic liver disease or previously known cirrhosis, then their resection capacity or regenerative capacity comes down, so the complication becomes higher. So you need to address that before you're doing surgery on them. And people with diabetes, obesity, or steatohepatitis, they tend to have less regenerative capacity. So you need to be careful about how much liver you're going to remove them. So they may limit what type of operation they can have. Similarly, previous chemotherapy is one of the certain chemotherapy drugs like oxaliplatin, irinotecan. They can cause swelling of the sinusoid and sinusoidal blockage, or they can cause severe steatohepatitis, and that could cause problem with the liver regeneration. So whenever on the ultrasound, MRI, or CT, when there is a doubt about the quality of liver, sometimes we do volumetry assessment based on, I'll go through that bit later on, but sometimes we do liver biopsy to say how big or how good the liver is, what extent of the replacement of the fat. So there are other factors we consider about the size, number, location of the liver lesion. The inferior part of the liver, well away from the major inflow and outflow, is easy to take it out. If it's towards a central part of the liver or superior part of the liver near IVC and major hepatic veins, then they're going to be tricky to take it out. And if you look at patients coming through colorectal liver metastasis, only about 15 to 20% of patients upfront will be ready, will have suitable lesions for liver resection. If you, for example, if you see this patient's scan, see this part of the liver, almost whole of the right lobe is involved by the tumor, and that white structure there, that's a middle hepatic vein, that's a left hepatic vein. So the tumor is right on the middle hepatic vein. If I go ahead and do an operation on this patient, I have to go on this side of the middle hepatic vein. That means I'm going to take out the part of the segment 4. So it's not right hepatectomy, it's going to be extended right hepatectomy. And this part of the liver, the left lobe of the liver is not too big, then the patient may go into liver failure after the operation. Once they go into liver failure, if they don't recover, it's nothing else we can do. They will die. So what we did in this patient, give a systemic chemotherapy, and you can see the same patient, that's a middle vein. The tumor has shrunk from this area towards the right side, so I can cut here safely, and this patient had a right hepatectomy. So the difference here in this picture, before chemotherapy, I would have gone here and take the whole right lobe away with some of the left lobe, but now I did just remove the right hepatectomy and save this vein and save the segment 2, 3, and 4, and that patient didn't develop liver failure. So reduction in size of the lesion, you can increase your tumor-free resection margin and increase the distance from important big veins and inflow vessels and bile ducts, and it increases the cure rate, R0 meaning no tumor left behind, either microscopically or macroscopically. So by downsizing chemotherapy, we have increased further 15 to 20% of patients who are not suitable for surgery or who are undergoing high-risk surgery. We are reducing the risk of the operation by giving chemotherapy. That's one development. So that involves quite a lot of oncology output for this group of people. Even though, say for example, that patient equally, he could have responded reducing the tumor response from right to left, meaning the distance between the middle vein and the tumor may not have come down. Tumor may have shrunk from right side towards the left side. So that situation is good news. Tumor has shrunk and responded, but the liver extent resection may not have changed. We still may have to do it extended right hepatectomy. So the volume may not be enough. So what we do nowadays is we measure preoperative images. We look at, suppose the tumor is in this area and this patient requires extended right hepatectomy. Only this is going to be left behind. We can measure the volume of this part of the liver, otherwise called FLR, future liver remnant, using computer graphics and software. And we can predict how much volume is going to be left behind, and we may be able to enhance the future liver remnant volume by doing certain procedure. So this is a procedure called portal vein embolization. You can see in this portal angiogram, you can see the contrast going to the portal vein. This is right vein, this anterior sector, the posterior sector. This is left vein, which divides into segment 4, segment 2, and 3. So this patient requires extended right hepatectomy. So coils are put into right posterior sector, right anterior sector, and in segment 4. So the segment 2, 3 has been left behind, and we do that procedure. So that's after the procedure being done, and 4 weeks after the repeat CT scan shown that this part of the liver has grown significantly, and that patient came for extended right hepatectomy and didn't have any problem post-op. So this procedure is done as a day surgery procedure with overnight stay. They have minimal adverse event as long as it's done by an experienced radiologist. And over half of people who underwent portal vein embolization will develop enough hypertrophy and come for resection. Some of them may develop hypertrophy, but unfortunately they may develop new disease elsewhere, and that makes them not suitable for operation. So if they didn't have a chemotherapy, 25% of the normal liver is adequate. If they had chemotherapy before, we need minimum 30%. And if they're cirrhotic or fibrotic liver, we need up to 40% before we do the operation. So these calculations help us to reduce the risks around recovery time with the liver failure. What are the indications? The secondary cancers are, if you look at any liver unit, 90% of liver resections are, now 85% of liver resections are done for colorectal liver metastasis, about 5 to 10% done for primary cancer, hepatocellular carcinoma, intrahepatic cholangio, hyalocholangio, and remaining 5 to 10% done for people who had a suspicious tumors. Radiologists couldn't tell us whether it's benign or malignant, and in that situation, they have index of suspicion more towards malignant, then we may have to take it out. And about 10% of our resections post-operatively may turn out to be a benign tumor. And if, even though we know on radiology it's a benign tumor, if they are symptomatic, for example, large hepatic adenoma, which is ruptured and bled, so we may have to take it, or risk of cancer, it becoming in future, then you may have to take it out as well. Liver surgery is truly a multidisciplinary team. It involves quite a lot of people, a lot of resources, surgeons, oncologists, radiologists, both diagnostic as well as intervention radiology. You need to have an anesthetist with the transplant skills, anesthetist looking after patients in critical care, and you need a good quality pathologist because liver pathology is not common like a colon cancer. So you need a very good quality pathologist to differentiate benign from malignant and to say what type of malignant tumor that is. And you need to have a dedicated and very motivated gastroenterologist because the liver patients or alcohol liver disease are not very pleasant patients to deal with, not all of them. And these are done mostly in high volume center, catering population about 2 million, 3 million population, so that you can develop expertise in this group of people in dealing with this. In summary, I think I just went through how do you deal with when you come across abnormal blood test, abnormal liver blood test, and share my experience as a HPB surgeon. And if you want to work in a team which has got very exciting development and challenges for the future, I can only be HPB surgery and know the specialty. Raj, apologies to that. You're a urologist, I know. And this is the only specialty where you can be a physician and a surgeon. So I'm very happy, and thank you very much for inviting me for this talk. If there are any questions anybody has, I'm very happy to share that.
First of all, I thank all the participants because it's Sunday, and then for contributing your time. And then obviously Ravi had a prize from everybody, Ravi.
Thank you.
And the real celebration is that you are going to be called again.
Yeah, that's right.
Get ready for that.
Yeah.
And then of course Elil is co-host for his valuable time and the role he played. Then all the committee members, they were all here today. Although Grace disappeared for lunch probably. And then Chandran, it's nice to see Chandran's face. He normally doesn't join us, but it's a great day to see him. Jay Kumar, everybody, Amarendra, thank you for your contribution. Ravi, who else there?
Pratap is there.
Pratap, thanks for joining. Kailash Mohanty, thank you for your valuable contribution. Maybe you can give us ideas how to get big crowd. I did send this to Stanley Group, Coimbatore Medical College Group, but obviously, as Ravi said the other day, there are too many Zoom conferences in the country, so we are competing with other people. And thanks, Jay, for your contribution, your alcohol discussion. Did you hear that Pratap's comment about that? Huh?
Yes.
Pratap is an Akiran today for you. Okay. If nothing else, then I'll thank everybody and we'll close the meeting.
Yeah. Thank you. Thank you very much. Yeah. Bye.